to my pal's desk. People who always love to jump on the cardioversion bed wagon, and I was like, things we do before.
Let's take a break.
Well, has two sides. They have C1 and C.
I was telling the other day, it's like ended up defibrillating 5 patients in 4 shifts in cardioversion one. Like, that's insane.
Yeah.
I was like, it's time for me to take a break. They're gonna be glad for me to leave for a few days. So I brought that crap wagon with me. So I'm gonna talk a little bit about history and of where critical care came from, and a little bit of our EMS history, and I forget where we're at too. But we already kind of talked about that. Methods of transporting critical care patients have evolved from horse-drawn cars in the 17th century, right? We had, for the use of hot air balloons, the use of ground and rotor fixed-wing transport. Obviously, more efficient methods of transport, more rapid provisions of medical treatment, have increased the survivability of critical victims. I'm just waiting for the day that Star Trek is realized and you can transport a patient from point A to point B, and it will eliminate our business.
I will happy just for the wireless system.
I would be A-okay with
transporter is the whole tubes and wires thing.
Just like a pneumatic tube system.
I was going to say,
can I tube this patient to Raleigh? Can I tube this patient to UNC? Just pack them in there, it'll be okay. So ground transportation was first used in 1792 to evacuate soldiers during the French Revolution. The French army surgeon, Dominique Jean-Léry, noticed how many soldiers lay wounded on the battlefield for as long as 36 hours before they ever got evacuated. And this resulted in death, disability in many soldiers. So he designed a two and 4-wheel carts called an ambulance volante, flying ambulance, which were fast and maneuverable. These transported surgeons and equipment to the battlefield and then moved them to the nearby field hospitals. So their ambulance was, eventually recorded the first use of the evacuation system to help improve survival rates of soldiers, and credited with many of the first official Army Medical Corps using stretchers, carts, and wagons by means of transporting patients. Again, just a graphical representation. We think we got it bad. So America's first ambulance, 1862, during the Civil War, the Battle of Antietam. Jonathan Letterman developed a system known as the Ambulance Corps, which is the basis of the Army medical doctrine. And then in 1917, the U.S. Army Ambulance Service was established. First time they used trade ambulances, steamboats, hospitals, cars, trolley ambulances were even popular in some cities. So in 1869, America's first ambulance service was established by Bellevue Hospital in New York. The hospital dispatched ambulances via telegraph, which staffed with physicians and surgeons, and responded to about 1,800 calls the first year. It's probably pretty busy in New York in the late 1800s. So Bellevue Ambulance. That is high quality vintage care right there. I thought it was pretty cool. First motorized ambulance was built in Chicago. The Michael Reese Hospital by a group of businessmen. Unit weighed about 1,600 pounds and traveled 16 miles an hour. Whopping 16 miles an hour. In the early 1900s, so these ambulance crews evolved to include a driver and a person responsible for patient care, but only picked up and delivered patients to a base hospital. So the next step came in Ireland. These provisions of pre-hospital coronary care by physicians. Research by this French physician indicated that patients experiencing a treatable VFib or fatal arrhythmia outside the hospital. A portable, lightweight, battery-driven defibrillator is part of rapid response developed. And this pre-hospital defibrillation was not used until 1969 in the U.S. Shortly after that, the first paramedic program in the U.S. was introduced in Miami, Florida. Then versus now, okay, look at that. That's some big differences. Air medical. So transporting patients by air. After witnessing balloon flight demonstrations in 1874, physicians began to consider whether flights could be used to bring patients. So to improve care. In 1870, there's the first documented medical transport took place during the Prussian siege of Paris. 160 soldiers were transported from the battlefield via hot air balloons. At this time, it was considered radical, so it's met with harsh criticism. However, improvements were made, but pretty cool idea, right? You're in a siege of Paris. You've got to get them out. What a cool idea! Using the resources we have available. May not be the most timely transport in the world, but I thought it was pretty cool. Obviously, we're all right here. Orbital right. Everybody ever been to Kitty Hawk to see the Wright Brothers Memorial? It's a successful motorized flight. In 1909, the U.S. Army Medical Corps built a plane specifically designed to carry patients. However, its crashing did not really go real well for it working real well. In 1917, the first use of an aircraft was the French Dornier AR-2, served as an air ambulance transporting patients. And in 1914, Sikorsky invented a helicopter, which would later be used by military transport soldiers from battlefield to standard care. And after World War I, we took a new interest developing air ambulances, and we have made huge modifications at where we're going, really. 1930s, they were specifically designed with multiple engines, heated cabin, short runway capacities. So within the next decade, the push to create helicopters, transporting patients, continued. And 1944, several wounded airmen were transported during the battle of Burma in World War II. It's probably the first time they were transported by air or a helicopter mechanism out of the battlefield. After that, they determined, hey, this works, right? Let's keep going. And then we see, the first real evacuation of casualties via helicopters started during the Korean War. And then we had the development of crash hospitals. We had cots affixed to, we saw the old MASH movies of the skids of Bell 47s and Sikorsky S51s. These helped reduce morbidity, because we're moving patients quicker. Right? We're moving kids into definitive care. Got to be terrifying. Had to be terrifying. The back of a helicopter, you're going to be terrified anyways. I can imagine hanging out over the skin. Sikorsky, Bell 302, Sikorsky 302, Bell 47. Doesn't look like it has a plate icon, does it? Oh. No, it does not. And get the link. Here. You need this. Thanks. More. Just drink it. Fill up and drink it. Alright, so I thought I was going to be able to get that to link, but anyways. So we go from where we were back in the 40s, 50s to where we are today, right? This is a typical non-critical military medical flight. how many crew members were going to fit. It's the back of a C-130. Cool. Do an excellent job. Do everything from these to actual full isolate intensive care suites in the back of these that they could be loaded in. Pretty cool concept. I thought I had a picture of those too, but I don't know. It's in my phone actually. So the Vietnam War brought significant changes. We improved our equipment. We improved the capabilities of helicopters. So patient we carry inside the aircraft. Well, we can actually provide care instead of hanging out over the skids, because that's scary. So the Vietnam War, we transported more than 800,000 patients to specialty care facilities. So 800,000. You have rapid air transport with these specialty care facilities providing. Said a huge kindled interest in the use of air transport for civilian arena. So air medical transports were born. And just going from time frame, World War I time to injury to surgical care, 12 to 18 hours. World War II, 6 to 12 hours. Korea, 2 to 4 hours. Vietnam, 1 to 1.5 hours. I don't have statistics for Iraq and Afghanistan, but that's a whole other animal. There's a cool book on sidetrack surgical care in the trauma injuries in Iraq and Afghanistan. I meant to bring it, but it's actually really cool to read.
That one book, trauma surgery.
Yes. Yeah, that's what I'm trying to think of the name of it off the top of my head. Sitting on my desk.
Yeah, I don't know what it is, but yeah, I have it.
But the big thing, we talk about times, but mortality rates. So obviously correlation there, right? Our goal is to reduce morbidity and mortality. So certainly a great argument. 1958, the first civilian air medical service was developed in Northern California. So they began using helicopter to transport patients. Same thing in the 60s. The Europeans started doing it. Dedicated patient transports. In 1966, NHTSA, National Health Institutes and the National Academy of Sciences published Accidental Death and Disability, the Neglected Disease of Modern Society. So this paved way for initiation and growth of civilian air medical transports. Recommended the initiation of systems designed to transport patients via air ambulances based on a successful military role model. The reason this study is specific is because we showed it works, right? We had the ability, we have the data that we need to do it. We're just a little slow to get behind the 8 ball. And we're still growing at it, right? Mm-hmm. You see, in the last 2 years, we've had a huge surge in populations of air transport systems in North Carolina. But that's because legislation had to change to allow that.
Yep. Have you ever read the white paper?
I have not.
I read it one time back in late 80s or, Pam and I were married when I read it. So, my master's dissertation was on basically what had it really changed. And of course, the bottom line answer was it changed the percentage of death from trauma. But once EMS got established, we kind of got took over by cardiology and, sick people instead of trauma. I mean, what percentage of our job is trauma? Less than 10%. Yeah. 80 to 90% of our job is hauling people from home.
You are correct. And I'm amazed with the changes that have impacted legislation in the last few years that we've not seen we talked about community medicine and talking about preventative care, that we haven't seen a push to try to do more. We're doing more to try to keep people, or to send people home.
Or keep them home.
Once
they're back.
But once they're back, but we're not doing a good job of ever keeping them from coming to the hospital. And we want to send them home and nowhere else. And we don't want to pay for them to go anywhere else.
How many counties have community paramedicine? Do you know?
We have Iredell. Mission has a program. Is it scattered among all theirs?
It is not. Randy's in charge of it, by the way. Did you know that?
I didn't know that. So,
Randy is over it, and right now I think they're doing it in 2 counties, one being Buncombe and one being Yancey that they provide 911 for. But until HCA comes in and really takes over, Randy's not going to try to grow it because he doesn't know what HCA is going to do to it once they get there. So
less than 10 though.
Okay.
I would say it might be 15 who say they have a program.
Yeah, I think in actual delivery of services, less than 10.
Yeah. And
Durham, Wake, Buncombe, if Yancey's doing it, Iredell,
Charleston County.
are they actually delivering services?
As far as I know, they were.
Okay, I knew they were. Which one had a program?
And I think Pitt's.
Cumberland. So it might be more than 10.
You had over.
Yeah.
What's the county where?
Camden just announced about 2 weeks ago that they're going to be doing it.
Okay. What's the county where Marion is? Is that Burke or McDowell? McDowell has functioning program. And they might have actually been the first in the state.
So we had a program, and when it couldn't get funded, we dissolved it. It was, matter of fact, it was with McDowell.
Okay.
McDowell and First Health developed the first program in the state.
Okay.
And we couldn't fund it. So, and the hospital doesn't want to fund it. EMS more for it. So.
But that's what I don't understand is you would think that it would cut down on hospitalization.
It will. It absolutely will.
I don't understand why they won't get funded.
Yeah. It's finding the funding for it. It's like to find. So micromanagers see it as giving this department more money. The statisticians see it as reducing our readmissions. But they're getting these two lined up on the same page. Not working. And these don't make the decisions of everything else. So that's where it comes down to it, is trying to get everyone to play nice in the same sandbox.
Yeah.
And that's a huge deal when you got politics inside an organization, is to try to play in the same sandbox together. We're all on the same objective. Doesn't work out. So squirrel a little bit, but
No, that was within bounds.
So, 1969, the state of Maryland received a grant to purchase a single Bell Jet Ranger helicopter, instituting the nation's first public service medevac program. They quickly increased that and staffed 4 helicopters and paramedics as part of the Maryland State Police. They're stationed throughout the state and grew up to 7. And they have one of the most amazing programs for air medical in the United States, because they're not a private entity, they're not affiliated with a hospital. These are paramedic troopers 24/7, 365, that their responsibility is get to the sick and injured and get them definitive care. And it's government funded. What a concept that we put that entity in there. They don't just do evac there. They also do search and rescue, and they also do law enforcement operations. So these helicopters are up and running all the time. So cool concept, and the nicest equipment. It's a cool program that the way the state has actually decided to fund it. You couldn't do that in a state like this because Maryland's a lot smaller. They do have a lot of money to sunk into this program. But we talk about changing the way systems are done. We said, I don't understand, when you use universal health care, I don't understand why you can't do it. This is the argument I had with somebody the other day. I was like, you got to consider how hard it is to break the system down once it's there. And example of, I have Air Methods, I have Medtrans, I have PHI, I have all these individual companies, plus these universities, plus these public entities that are involved in this program. We use the state of North Carolina, for example, that have this program. The state comes in and says, we're going to add 10 helicopters in the state of North Carolina, because that's what it would take, 10 helicopters, at least, to do these operations. They're going to be function under the Highway Patrol. You're talking about taking millions and millions of dollars away of income. You're talking about jobs, equipment, financial thing. This is the same thing you talk about when you say we're going to just have a single payer source system and the government's going to run all healthcare. You've got Blue Cross Blue Shield. You've got United Healthcare. It drives 20% of our economy. It's not going to happen. You can't break it down. Only reason it's successful in Maryland is they started in 1939. They built it, and there's no real room for anybody else to get involved in that. The state's small enough for that purpose. So we see a lot of talk about the problems with private services right now. I'm not going to get involved with what's going on with Air Methods and all their issues. It's not just them. It's everybody, but they're the ones in the public headlines right now. So, I am the last person to advocate for more government and government-run programs. I think the government's in way too much, but when you build the program from the ground up, it can be successful. I squirrel for a minute, but 1972, the first hospital-based transport program was at St. Anthony's in Denver. And then NHTSA released a study entitled Helicopters and Emergency Medical Systems to Experience to Date, which following continued skepticism, the study stated that the use of helicopters in urban settings had little or no advantage over ground EMS systems. We still see that skepticism today. And it's not all that flawed. It really isn't in some instances. So, I'll explain why in a few minutes, but in 1981, a second report released their air ambulance guidelines, which indicated that air ambulances were improperly equipped to handle ill or injured patients, so nothing more than flying taxis with removable seats. This statement prompted the FAA to demand better equipment, specifically trained crews for the air ambulances. And thus, we have the development of air medical programs. The helicopter has been an obvious choice for ability to land and take off vertically with or without an airport. So with the help of specific technologies to advance education providers trained at intensive care level to deliver care in a transport environment. And today there's more than, it's actually low, there's way more than 600 medical programs in the United States with flight crews involved. My videos are not linking in here, by the way. Oh. Sorry about, I was trying to give you a little history and I get sidetracked when we talk about history because it's cool. I think history is one of the most amazing things and we don't talk about it enough because everyone likes to talk about their own version of history right now. So we'll talk about this for a little while and then we'll stop for lunch in, 30 minutes. Is that okay? Works for me. Cool. So, ethics and morality. Morality is guidelines to preserve society. That is not something, as we talk about being able to regulate morality, and morality is not one of those things that you can really regulate as a sense. It is a course of action. Ethics are a systemic, reflection on morality. And values are language we use to talk about things that we hold dear. We all have our own perspectives as what we think is moral, right, and just, and what is ethical. And talked about that ethical dilemma earlier. I'll give you a few more ethical dilemmas as we move on. So duties are describe actions imposed on us by ourselves or others. So what are our obligations and duties? So principles of ethics, non-malfeasance. This is all basic background stuff we all remember from initial education, but it's good for review. That I am in a position to do harm, but I'm not going to do it. Obviously, that's not my intention is to not do it. But beneficence, I'm in a position to benefit, and fidelity, I made a promise that I'm going to do X. Usually, work for the benefit of the patient. Autonomy is I have the opportunity to exercise my freedom. Veracity is I'm in a position to tell the truth. And justice meaning that I'm in a position to distribute benefits and burdens. These are principles that apply to every one of us every single day. Every day you go to work, you are in a position to cause harm or do no harm. You are in a position to provide benefit to your patients. You've made a promise to not do that. You have an obligation to tell the truth. You have an opportunity to exercise your freedoms on multiple different levels. We have a very broad application of how we can work. So most of us work in a very autonomous environment, and we probably wouldn't do well in an environment told we can't do that, or where we told absolutely have to do it. I would do it nuts in a factory situation where I did not have the freedom to do certain things. Ethical decision making. So, well, you have to clarify what must be decided when garnering an ethical issue. Gathering relevant information pertinent to the issue. Decide that you evaluate everything and make a judgment. Let me go back to that example earlier. Your partner that's using drugs of some sort or stealing medications. That's only a decision if no one else knows. You have an internal ethical argument that you have to grasp with. You have to determine what needs to be decided. Okay, I've confronted him. Am I going to tell my manager? Do I need more information? This is what I got. And evaluate it all and make a judgment. See what's in the best interest of everyone involved. Not just them, not just you, but everyone. Then, implementing that involves developing a plan. And evaluating that is when you decide you're going to go to your manager. All hell hits the fan, and you have to figure out how you're going to clean this up. I say that as a joke, but sometimes the decisions we make don't necessarily turn out the way we expect. So evaluation and turn around and needing to reevaluate and re-present our situation. You as a healthcare provider have an obligation to facilitate patient care, to place in the welfare and the rights of the patient above all other considerations. That's why I said earlier, absolutely do what is in the best interest of the patient in all situations. Obviously, safety is a big deal, but I don't mean jump on the grenade. I mean do what's in the best interest of your patient. So, give you some scenarios here. So you're about to transport a patient or a 19-month-old child to another facility. The patient or parents arrive and insist that they want to give you cash to take good care of him. So what should you do in these situations?
Take it.
Take it. Yeah, I know you're good. Yeah, that seems kind of a no-brainer, right? I think coming down to like saying, hey, obviously we can't take that, right? That's not the way it works. Explaining this. Tell them you're going to take good care of their son or daughter.
Never extra $5.
Yeah. That money means more to them than it means to us right now. Because, they're going to get this $3,000 ambulance bill, and they're going to need that money.
Right.
Just kidding. So, a man arrives at your company's business office and having quite an argument with your office manager. He wants a bill for his neighbor's recent ambulance transport so he can take up a collection and pay for it. The office manager insists that he cannot give us information without HIPAA restrictions. Do you have an ethical dilemma here?
You have a legal one.
Yeah, you got a legal one. You're right. How should you handle it? I mean, there's no right or wrong answer in this instance, but if there is, obviously don't give them the bill, but these are things that we don't necessarily think about, we encounter at times, but that can come up.
Without violating HIPAA, the office manager could say, our base rate is $2,000. We perform additional procedures which drive the bill up. But if you want to do a fundraising, the base amount is $2,000.
There you go. That would absolutely be acceptable. Because then you get into the whole thing, well, Billy Bob's on Medicare. They got Medicare, and he's going to start to pay for that. So,
True. So
and when you start getting
our base rate's $2,000, and Medicare is going to give us back $150.
Yeah. And when you start talking about when you start talking about money and things.
And yeah, does Grandpa want a fundraiser?
Yeah.
Does he have excellent secondary insurance and he's going to pay it anyway?
Maybe. So that's the whole thing. But you're probably on point. That may be the only real direction you can go.
Yeah.
So. So the case study we talked about earlier is in the beginning said you believe that you're morally correct to notify your employer and the certifying body so that your partner's behavior. So in this decision, you said you're considering which one of these factors. The conscience of heart, the bylaws of your employer, the expectations of your medical director, and what your partner would want if he were thinking clearly. What do you think? Which one of those affected?
All of them.
All of them, probably. I think, all of those. And really, I think the conscience of heart for me as, not wanting to do harm to anyone. That plays a huge role. And that scenario, very, very involved. You got somebody stealing, they're using, they're probably high at work. It seems pretty straightforward to me until you actually see it. And most of us never get to encounter it. But it absolutely happens. So, unfortunately, the opiate demon is with all of us every day in some way. We're all touched by it. So. One second. pre-hospital law, talking about medical practice, so delegations of authority in relation to the things we have. So functioning under in a pre-hospital care environment. Who are we working for? Who do you work for?
And I would say my agency, but also the people.
The people, okay. Whose license do you work for? I guess is my best medical director. Yeah, your medical director. So, we're physician extenders in that instance. How are you given your authority to work? We have work under SOPs, we have protocols, standing orders. We're given that kind of leadway and freedom. We'll talk about tort liability, what a tort is. And a tort is a civil wrong. It's a breach of contract committed against a person or property in which a court provides a remedy in the form of an action for damages. So, tort is a civil liability. The element of fault is generally not just because an injury occurred or an outcome was bad. It actually has to have a actual element of fault involved most of the time. So, in order for tort claims to, why they're put in place is, to substitute for retaliation to keep the peace. Find fault, culpability, in some instances, deterrence from it happening again, and compensation for to indemnify an injured person. So this is why we have the civil court system. It's not to punish somebody. It's not to make them pay. It's not designed to do that. It's part of it, but I'm coming back to the instance of the case in Pitt County again because I beat back then. Their goal was not to make millions of dollars. Nothing can replace the life of your child. There's no. So the good that came out of that was the fact that mandates to improve pre-hospital education, pre-hospital care, or in the realm of waveform capnography, came trickling down from the state because of that. So, yes, it did find culpability. I don't think it was an instance where there was going to be retaliation as far as a violent issue, but deterrence maybe, and hopefully deterrence from it ever happening in the future. So, medical malpractice. The primary rationale is compensation for the patient and deterrence for providers and society in the future in order to prevent any of these things from actually occurring in the future. So, issues of a concern for medical malpractice, excessive awards, like mentioned last night, the talcum powder award of $4 billion to 22 people. It was kind of excessive, right? $4 billion, 22 people. So, but part of that is into a fund for others affected by talcum powder. Defensive medicine. You've ever seen an example of this? I'm gonna have this position is going to work on everything in the world because they don't want to be sued. So, another reason that drives up our healthcare costs. Time and expense.
Pardon me.
Yeah.
You're familiar with the checklist manifesto book?
Yeah.
That's defensive medicine, isn't it? I mean, having a checklist is defensive medicine. And I'll tell you guys, Wake County has started creating checklists for all the routine things we do. And their first one was cardiac arrest checklist. Check. Is someone managing the airway? Check. Is someone managing the defibrillator? Check. Is someone doing CPR? And so, you know, the senior medic on scene flips to his checkoff list and physically checks the boxes. If you don't check the boxes, it wasn't done.
I don't disagree with you. It's defensive medicine. I think their purpose is different, but because we've never really been focused on the defensive medicine aspect. Our focus on
get her done.
Like I said, get her done. Is our focus being more on the actual ensuring that we're doing. Now, our medical director very well may be biased on that portion because it's his license.
Yeah.
But the long story short of it, we're focused on providing the care. And I'll come back, or I'll mention the U.S. Airways flight that landed in the Hudson. The
checklist manifest.
Checklist. Checklists work.
Number one.
Perfect example. Number one, fly the plane.
Fly.
Because he's flying a bucket of bolts that's got no engine now. And you could be so focused on everything else, if you don't have something to guide you in a stressful situation, you're going to forget something. So, I think number one on that checklist, when those birds hit that aircraft and knocked out both their engines, number one thing on the top of the checklist, fly the plane. So somebody's got to fly. Somebody's got to guide the ship. And the checklist helps with that. That's got a whole neighbor application on a lot of different scales that I'm not getting into in this class. Time and expense, mounting a legal defense is costly. Sometimes it's less costly to just settle. And that, unfortunately, sets a bad example too, because even if you did nothing wrong, the insurance company might settle and pay these people just because it's less expensive. And it doesn't make, all it tells the next person is, well, I can do it, make $1 million. So it is costly across the board. Supply and recruitment of physicians. This comes for a huge, broad scale, not just medical malpractice, but where reimbursements go in general. Ordinary negligence versus gross negligence. Ordinary is failure to do what a reasonable person would do or not do under the circumstances. Gross negligence would be the intentional or wanton omission of care that would be proper to provide, or doing that which would be improper to do. This would be transporting a patient on a ventilator without waveform capnography now would be considered gross negligence because it is a standard of care. Negligence does not require intent. Failure to use reasonable care under the circumstances or follow a standard of care. Medical malpractice is negligence because generally there is no intent. Nobody goes out with the intent that says, I'm going to go operate on the wrong knee today. Nobody does that. Does that happen? Do wrong sites surgeries happen? Absolutely. The physicians do not go in there to do that. The reason that happens is multifactorial. One of those reasons is, comes back to finances too. They have to do X number of procedures in order to meet X number of lifestyle or whatever their goal is to do that. So, this need doesn't look very terribly much different than that need from person A to person B. So, it happens. And if you've ever been to an operating room, the patient's not exactly visible to you, so it's not like I'm, like, oh, this isn't Bill, plus I've got 3,000 patients. I don't know Bill individually really well, unless Bill and I are buddies and we go golfing together. Elements for a cause of action, there must be a duty and obligation to conform to recognize a reasonable care under circumstances. So you look at the standard of care and and use that experts use to establish this. A breach of duty by failing to meet that standard of care. Some damages, or whether they're compensatory, actual or non-economic or tangible losses. So these could be actual damages, or they could be perceived damages. And causation, the cause of the injuries or damages not occurred in a way that was different for the reason or foreseeable. So the damages were, or the causation was directly or related to the action itself. The damages awarding the sum of money that a judge or jury imposes for a breach of duty. Compensatory economic damages compensates a plaintiff for past, present, and future harm caused by loss or injury. Places in the same position as they were before the defendant's negligent act. This could be economic expenses, wages, medical expenses, earnings, lost potential, or non-economic. This is that pain and anguish, pain and suffering, loss of lifestyle, loss of a chance life. Or punitive or exemplary. We're doing that to punish them, set aside. And I think we're going to see punitive damages imposed by the U.S. District Court against, like, Lori Loughlin in that instance of this college cheating scandal, because they're going to punish them to set an example to make sure this doesn't happen again.
Especially those that have pleaded not guilty and are going to go to trial.
The federal government hates that.
As opposed to those who fell on their sword.
Yeah. The federal government absolutely hates cases to go to trial, and they will make an example out of those people. Mm-hmm. And I say they don't charge people
randomly
to dismiss cases. The U.S. attorney has, if 1,000 cases get presented to the U.S. attorney, less than 3% actually get charged.
Is that right?
So they don't charge people.
1,030.
It's not like there's the local detective going down to the magistrate and swearing a warrant against somebody for, they're not going to take a case to court unless they can convict somebody.
It's a FIBI to start with.
Yeah.
Or a U.S. Marshal, or
yeah. So it's
we ain't playing.
Right.
Where's Princess today?
Yeah. Got me. I just show them talk.
Okay.
So informed consent, and we'll talk about consent, and then we'll cut it out because you're tired of listening to me talk for a minute. Consent is a voluntary agreement by a competent person. It is either implied via silence or expressed via verbal or written. Patient Self-Determination Act of 1990 that said Medicare, Medicaid conditions of participation. Make sure that patients know that they have the right to have decisions concerning medical care, including the right to accept or refuse medical surgical care, which includes transport. Adults of sound body and sound mind have the right to decide what is done with his or her body, have the right to refuse. Just because they need help doesn't mean they have to have help, right? Consent must be fully informed. Patients' rights, they must know the potential risks, benefits, and alternatives of a proposed procedure. Why? So there's always a chance of risk or injury. There's always a chance of complication, even though I'll give you an example. I'm going back to my wheelhouse right now. Example of heart catheterization. We do thousands of them. They're very, very safe. So there's less than a 2% chance of complication in most instances. But those complications relate to, severe MI, stroke, death, severe bleeding, kind of serious, right? So there's always a risk. It doesn't matter how safe a procedure is. If there's always a risk of death or harm. You put a patient in the back of an ambulance and take them to the hospital. Is there a risk of death or harm? We're just going down the road. We put a patient in the back of a helicopter and we fly and we catch wind shear. There's always that risk of death or harm. So they must be well informed because there's no guarantee of the result. Patients should know what they're getting into, regardless of the risk and circumstances. Based on the information that would be ordinarily provided to a patient under like circumstances by healthcare providers engaged in similar practice is what we're supposed to provide to these patients. Just because the patient's going for emergency surgery at XYZ hospital from a smaller community hospital, that's not our job to get the consent for that. It's our job to get the consent to actually make sure they're consenting to leave the hospital. They have to consent to transport. Most of the time it's already done before we ever get there, which is fine. But who can give consent? Patient themselves when they're competent, a guardian, someone with a durable power of attorney, parental consents for minors, whoever authorizes the person must have significant information to make an intelligent judgment on that behalf. And I'm going to stop at treating minors before lunch because that actually goes a lot longer than I want to talk about. So, lunch.
How about the honey baked ham store?
Sounds good to me. What time are we coming back?
What time have you got?
I've got 11:45 right now.
1:15?
Sounds good to me.
Everybody on Zoom can concur with one.
All right, cool. So, we'll have off this consent. Sorry, I'm sucking out peppermint right now, so if I spit it out, I apologize. About treating minors, and all kinds of issues. This always raises concerns when we're talking about transporting minors. You have access and liability issues, confidentiality, economic constraint, constitutional interests, and appropriate consent. Who is truly authorized to provide consent? Obviously no definition of a parent, but what about a legal guardian? What do you consider the definition of a legal guardian?
Could be grandma, could be,
Could be. It's whoever has care, custody, and control over that child, right? Then we come into that whole funky mess of, well, you truly is a legal guardian. I don't know, I'm not going to split too many hairs on it with an emergent situation, but it does pose some challenges at times. San Juan. Obviously, they do have an emergency exemptions. There are immunity set for assault and battery, for any condition that requires prompt treatment or urgent attention or was causing a child pain or fear. No parents are reasonably available. You're going to act on good faith, right? We're going to treat the kid. Some of the things that even come into play in protections for us in North Carolina specifically is if a child's in danger, do you have the ability to remove that child from that situation? Without law enforcement, yes, we have that ability. Most of us won't go that far without some kind of help. But if it comes to the point of kids in danger, oh hell yeah, I'm going to take them out of that situation. regardless of, what it might cause, if it's in the best interest of the kid. Yeah, it's not leaving them in the crack house just because they don't want to go to the hospital. Well, you're not going to stay here. Social services might give them back, but at least we have to make them do their job. All right, mandatory reporter. Are we mandatory reporters? Yeah, absolutely. What do I mean by mandatory report?
Child abuse.
Child abuse. Yeah.
Elder abuse.
Elder abuse. Okay, so anybody that's a dependent adult child that's being abused, whether it's physically, emotionally, mentally, psychologically, mentally, same thing. Elder abuse is financially, so we have that obligation to report to Department of Health and Human Services or CPS or whoever the reporting body may be, who would be law enforcement, CPS, or the district attorney's office. There's clear guidelines of how that has to be reported. This supersedes HIPAA. This supersedes, because there's an exemption in HIPAA for issues of violation of law. So, we're basically required to report that, especially as a mandatory reporter. We're required to report that. Sexual abuse, anyone's required to report for sexual abuse of a child. And there's actually a misdemeanor offense if they don't. So a lot of people don't know that. There's actually a criminal charge for failing to report. Doesn't happen most of the time, but it does exist, at least in North Carolina. I'm sorry. My little thing is not wanting to cooperate. So, give you a clinical scenario here for the ethical reporting criteria, or not ethical, not reporting criteria. Where is it? I thought I had a consent scenario here, I'm sorry. Okay, well, let's create one then. You're going to a small community hospital to pick up a patient being transported to a tertiary care facility for whatever medical emergency it might be. You get there, you introduce yourself, and so you say, hey, you're going to be, I'm going to be help you, or be your transport to wherever, UNC, wherever it may be. Patient looks at you as they don't have a clue what you're talking about. Does this happen? Yeah, absolutely. So what do you do?
Usually go back to, whoever the patient's nurse is, because it's not my job to tell you where you're going.
Right.
And say, how do you inform said patient that they're being transported? And sometimes they go, oh God, no, we never did.
Yeah,
Or, yes, we did, and, she's demented.
that's a good point. The patient got dementia, if that's the case, then certainly understandable.
Family members need to know that, who's working this. So, oh God, yeah, no, we told her she didn't want to go. Well, then why am I here?
Yeah, when you get looking through the chart, there's signed consent for transport. Okay, maybe there are some memory issues that's going on. It depends on the patient condition, or family members are aware. I've certainly gone to pick up the patients, and family members like, no, we talked about this. Like, okay, so everyone's on the same page. You just not following. Best way to handle it, like I said, go back to the nurse and then just a slow reiteration to the patient, because in some of these communities, I always say the index finger test. I joke, I say they're like index finger test. What do you mean? It's like, tell me, can you point with your index finger? And they're like, the person goes and holds up their hand, looks at their hand, like trying to figure out which one their index finger is. So I'm trying to assess how well their reasoning and how well our conversation is going to go to determine. If they can't like figure out which one their index finger is, I'm going to have to like dump my conversation down a little bit to the lowest common denominator. The index finger test is a joke, but we deal with people who are really, really well educated with it down here, and we deal with people that do not have passed a grade school education. So, unfortunately, in eastern rural North Carolina, we have a lot of very, very poor, uneducated folks, and we have to consider that when we're given terms about it. Say, we're transferring you. Well, what does that mean? I know what transfer means, but the person that doesn't comprehend, we're needing to take you to a different hospital that's capable of handling X, Y, Z. Do patients at times refuse to go altogether? Yeah, absolutely. Not real common, but it happens. So another scenario, have a 15-year-old involved in multiple trauma, multiple trauma, system trauma, needs to go to a level 1 trauma center for emergency procedure. No family members are there. Nobody can get a hold of anybody on the phone. What do we do?
Sort of an implied consent to that, I think, given the nature of the emergency, whether or not she's alert or not.
Yeah. So, yeah, you run into, it depends on, hospital specific is where that's going to come into. Usually if we get there at this point and they decide to transfer and talk to a family member, their risk management, the physicians are well involved in this. And it is going to be an implied consent on our part to do what's best for the patient, because if we don't get the patient to where they need to go, they're not going to live. That's the ultimate big crux out of that. We can't let them die. It's the animal. Now, I'm trying to throw a monkey wrench in here. How do you resolve a issue between two parents? One wants them to go, other one doesn't want them to go, and they're having an argument there in front of you. It's not really our responsibility to resolve this at this point, but what happens? I mean, devil's advocate.
I'd have to say, who has the majority of custody, depends on the custody agreement, who was in care of the patient when something happened. And
I'll take credit for that.
kind of go from there.
Yeah, I think there has to be a serious conversation to take place.
Did you leave your tape?
Yeah, I did. Yeah, fill my water up with tea.
So now I'm gonna drag it right around the parking lot.
Surprise, surprise, surprise. But yeah, exactly what you're saying. I think it's going to come down to a discussion that needs to take place between the provider and those two parents, because the Billy Bob and Billy Bob's baby mama may not have a full grasp of what's going on and what needs to be taken care of for that patient. And look on the bigger picture here. So again, we're probably not going to get into the big crux of the animals of we're showing up and there's no consent. Usually consent, the it is a rarity that we will arrive and consent has not been established to be transferred.
I
I mean,
like I said, at that point, I'll let the nurse say, okay, y'all got 10 minutes to
yeah, we gotta get this
get your food together.
taken care of.
And, yeah,
Because that's part of it. That's part of the agreement. That's part of Intel is they have to get consent in order to transfer the patient. So that was supposed to have been done before we ever got there.
Do we want to tell them a little bit about what we concocted last night?
Oh yeah, we can do that.
You want the brainchild to talk about it, or do you want to talk about it?
I can talk about it. Give me just a couple minutes.
Okay.
So you get to a good stopping point here again. So in critical care medicine, it's essential to make the right decision for the right reasons. Sometimes we don't make the right decisions. And when I mean right, I mean being what's just and proper. I don't mean that it's exactly the right, that the answer to everything. So being what's good in accordance with what's just and proper in relation to the patient. So that is ethical, it's visceral, it's moral, it's clinical, it's legal. It's all of these things come together that we talked about earlier. We talked about, I thought I had this actual scenarios load, but they don't. But. So another scenario, a patient is unresponsive. You're being transported, or you transported the patient. You have orders to administer blood. You get looking through the patient's chart, and there's no blood consent, or you've noticed that the patient has a history of being a Jehovah's Witness and absolutely refuses blood products. The patient needs blood. What do we do? Yeah.
I mean, I feel like you have to go with what is most appropriate for the patient. And I always say it's better to ask for forgiveness than permission, but I think in those instances, if they're unconscious, they're not able to say no with the right mindset.
And I'll say, previously, you're seeing previous documentation where they have
Maybe it changed their mind. You don't know.
Okay.
So they might be okay with getting blood now.
All right. I'm going to be a severe devil's advocate on this, and I tell you what you want. If we didn't know, that's one thing. If we have no idea, if it's an emergent situation, especially especially if we're on a scene call, on a flight crew, and I end up giving back cells to a patient. Okay, it happened. We turn out patients a Jehovah's Witness and has a religious issue with blood products. Oops. We erred on the side of the patient. Being the fact that the patient has refused blood products in the past for religious reasons poses a real hairy situation all around, and I would not want to be the one to make that decision in the back of the truck without having some kind of clarity. This would be one of those instances where you would absolutely want to be referring to your online medical control because there's not a blood consent. There was no family to provide blood consent or the lack thereof. The only thing we know is there's a history of them refusing consent for religious reasons. So that's where we're going to draw from our resources to be able to ask, because I don't have there's no good answer for that. There's no clear-cut answer for that. I know what will happen if we have a clear refusal. You're not getting blood. That's the bottom line of it. They have the right to refuse for any reason. Religious exemption is one of the most profoundly respected reasons. as far as us providing or giving blood product. And I don't understand it all the time, personally. And I don't understand the background of it. How about that? If anybody knows more about the background of Jehovah's Witness or some of the other religions that prohibit that, please, I'd love to know. I don't. I know some other ones, but absolutely, if you don't have, if there's a question of the clarity, absolutely seek guidance from those, because it will ultimately, and that's come back on us. If we didn't know, we didn't know. We're functioning understanding protocol. We're functioning understanding order. We have no idea that there's a refusal. It's an emergent situation. That's a different scenario. But we see this in the past, that they refused it, or they were given this report in the ER, or the originating facility, the patients refused blood in the past based on religious exemption. I would hope more groundwork has been done before we ever get to that point, but we need to make sure we're doing something to cover ourselves. Because it is, I don't want to ever be put in that situation. You're right, though. Acting in the best interest of the patient is what we want to do. But physiologically, or physically, or spiritually, is one more important than the other? I mean, physically, if we don't treat them physically, they're not going to be on this earth. So you could argue that's more important, but spiritually to them, which one's more important? So I got to look at both sides of that. I can't place a single, say, yes, their physical condition is more important than their emotional or spiritual condition, because I see that every single day, that we keep people alive physically that probably should not be there. And we interfere with natural selection on a daily basis.
That's really what our job is.
Yeah. If you get another kind of a ethical quandary decision. Go to transport a patient from a smaller hospital. Again, I'm just going to use those as an example. Patient is a Muslim, female Muslim. You have two-person RN paramedic team, both men. What's the most appropriate way to handle this? Do it?
I have run that call, only with me and my partner. My partner was a male that had hip replacement, got a nice post-op infection, and I had to go from her rehab facility to our care. And I went in, and they were both, scarf, she had a black burqa thing. I said, didn't speak very much English, looked like her daughter did. And I said, okay, here's my thing. My partner is a male. Do you want me to call and get another person who is a female because we're going to have to touch you? Is this, and she says, can you talk to another person?
Whatever it may be.
Yeah, Middle Eastern dialect, whatever. But, and she said, no, her mother said no. She understands that this is not her reading, and this is what we're going to do. But, my partner is a male. He's going to no, we're good. And that was, but I was like, okay, there is another female on this shift. Do you want me to have her urine? And they're cool with it. It went out, without issue. But, when I walked in, I kind of stood at the door.
So it's a legitimate issue, and really most of the time it can be resolved with communication. And it works both ways, both female and men, because men have issues about being women instead of or someone of the opposite sex as well. So I had a young man who had a female partner, same situation. The mother was adamant that the female partner, female, did not be involved in his actual care. Or not, I say not involved, not be the one caring for him, or basically touching him. In the instance of two male providers, I think communication is going to be really bad, because in a lot of instances, we're not going to be able to stop and wait. Your patient condition's not going to allow for it. But calm communication among everyone to be able to make those accommodations. And obviously, we respect the honesty of the patient, do as minimally invasive assessments as we can, while keeping the patient private and in control of themselves as much as we can. But you're right. Talking to them and communicating is going to be the best thing, better than just normally what we do, like a bull in a china shop coming into a scene and take over and start assessing the patient without talking to them. But we don't get to have these interactions with certain populations very often, so we forget. Even going to patients' homes, like we don't think about the respect that we owe to families of. And I'm going to go back to Muslims again. A lot of them will have a special prayer room in their home. There's things there like no shoes in the prayer room. We don't ever think about that. It's extremely disrespectful from an aspect for someone to be in their home or in that room with shoes on. We don't ever think about that, and I'm not saying that we need to stop and on nice boots and all that stuff. Just one of those little conscientious things of if we can avoid that room, let's avoid not traipsing the stretcher through there.
You also have, your again, not one of those high level of care kind of things. And you have your critical patients, and when we want to pray for her before she leaves, it's okay. You got too quickly.
Yeah, I had we got to pick up a patient the other day, and we've been to our hospital. The patient's in basically the furthest way we can get. It's like almost a half-mile walk from their room to our cath lab. And they're going for a complex intervention, and they're not coming back to that room. And so I go up there with a transporter, like, ready to get the patient. They're like, "Hey, we want to pray." I'm like, "Okay, that's fine." And the transporter obviously didn't hear that because he comes in like, "Okay," I'm like, "Shut up a minute, okay?" Kind of like look around, see what's going on. But everyone's standing around like, pray, pay attention.
If she goes die, so let's go.
So yeah, that's I get that a 15-minute snake handling prayer is probably not going to be tolerated. Snake hand. I'm trying to think of
Well, you can try to be as polite
as accommodating as we can.
we want to pray for her. Yeah,
We have to go.
She was in, NPC, head injury, swelling. She needs
prayer.
now.
There's no doubt about
She
that.
does need prayer,
she needs to start going to
she really needs my gas pedal therapy more than she
Yeah.
needs prayer at this point. Thank you. Thank you, Lord. Let's go.
So, the Emergency Medical Treatment and Active Labor Act